Hello, my name is Dr. Bridget Scott, and I'm delighted to welcome you to this Omron-sponsored webinar, Challenges in Recognising Wheezing in Young Children. Joining me today are three great speakers, Professor Saglani, Clinical Research Nurse Evie Bingham, and Dr. Elizabeth Scotney. Saglani is Professor of Paediatric Respiratory Medicine at the National Heart and Lung Institute, Imperial College London. Professor Saglani leads the Paediatric Severe Asthma Group within the section of Inflammation, Repair and Development at Imperial College. She is consultant in Paediatric Respiratory Medicine at the Royal Brompton Hospital and part of the Paediatric Difficult Asthma team. Evie Bingham is Clinical Research Nurse, Paediatric Respiratory at the Royal Brompton Hospital, London. She helps to deliver research studies and clinical trials both at the Brompton and across the UK involving children and young people who have asthma and preschool wheeze. Elizabeth Scotney is a Clinical Research Fellow at the National Heart and Lung Institute, Imperial College London. Dr. Scotney is in the second year of her PhD investigating biomarkers associated with clinical response to treatment with omalizumab and mepolizumab in children with severe asthma. She has organised regional and national paediatric respiratory teaching days and was South London Paediatric Trainee Representative on the Royal College of Paediatrics and Child Health Trainees Committee. The views and opinions expressed are those of the speakers and are not necessarily those of Omron, EMG Health or European Medical Journal. Professor Saglani will start the webinar off with a presentation on recognising and diagnosing wheezing disorders in preschool children. Sajal?
Great, thanks very much, Bridget. So welcome everyone, and talk about the difficulties surrounding the recognition and diagnosis of wheezing in preschool children. I'm sure most of you will appreciate how tricky this can be. Just before I start, just wanted to let you know that everything I say today is very much my opinion and may not be necessarily the opinion of Imperial College London, although of course I do work for Imperial College London. Great. So why do we need to talk about wheezing specifically in young children and preschool children? Well, essentially, half of all young children under the age of 6 will have had at least one episode of wheezing by their 6th birthday. And of those, a third will go on to have recurrent, difficult, severe episodes. And they are the ones at risk of developing asthma by school age. And the ones that do develop asthma are at risk of going on to develop low lung function and have problems through to adulthood. So it's kind of a lifelong impact of recurrent wheezing. So it's really important that we get the wheezing right and we get the diagnosis right and we manage it properly. And the sort of most common factor that tends to cause wheezing attacks are viral infections, viral respiratory infections, really with coryzal symptoms. And they're the things that in the susceptible children result in them presenting to emergency healthcare. And really, we need to talk about this and get the management right, because at the moment, preschool wheezing accounts for a third of all healthcare costs for childhood asthma. And that's kind of a global problem. It's not just in the UK. And if I tell you more specifically about the UK, the worrying thing is if we look at the burden of preschool wheeze, first of all, in primary care, so children presenting with wheezing to general practitioners, you can see that over the last sort of 10 to 15 years, not only have children been presenting to primary care with wheezing, it's the slope of the lines is increasing. So presentations are increasing. We're not going in the right direction in terms of reducing attacks of wheezing in these preschool patients. And if we look at the children that are bad enough to get admitted to hospital with wheezing, what you can see is about 75% of all admissions for acute wheezing and asthma in any age child, 3/4 of them are in children under the age of 5. So preschool wheezing is a real significant healthcare problem. And the way it presents, I'm sure you're all very familiar with this, is with acute attacks. And there's usually a peak of attacks every year around the time of sort of September, October, November, or during the autumn. And that's when viral colds hit and children have an attack. So what is wheezing? Well, I'm sure most of you know this, but the lungs essentially can be thought of as sort of an upside down tree with a tree trunk and then branching airways, the breathing tubes. And then at the end of the airways are the kind of pockets where gas exchange occurs, where oxygen is delivered to the blood and carbon dioxide is absorbed and breathed out. The part of the sort of lungs that are affected in wheezing are the airways, the breathing tubes, and they become narrow and result in wheezing. Why? Well, because if you have a normal patent tube, the airflow through the tube is what we call laminar. It's straightforward and there's no noises. Laminar flow does not make noise. But in a child who has wheezing or a narrowed airway, the airflow through that tube becomes turbulent. And it's that turbulent flow of air that results in the noise of wheezing, which is, as written here, a high-pitched whistling sound, predominantly when you're breathing out, that when the kids are breathing out. And this is what it looks like if you did a cross-sectional through the airways of a child. On the left is a normal, patent, healthy airway. And on the right is what an airway would look like during an acute attack of wheezing. As you can see, the actual hole through which the child can breathe is significantly narrowed because of mucus that builds up in the airway, but also swelling from inflammatory cells that build up in the airway. And the combination of this results in wheezing and an acute attack that presents to casualty. So what is wheezing? What does it sound like? It's really important to get this right. And because of this, I've got two examples of breathing noises that I'd like you all to listen to so that we're all on the same page and we really understand what we mean So they were two examples of wheezing, and well, one was an example of wheezing, which is the high-pitched, coarse whistling noise when children breathe out, and the other was an example of stridor. And the reason that was there is because I wanted to make sure that we can distinguish those two noises. Wheeze occurs from the lower airways, not from the airway above the level of the trachea, so not from the upper airway or the main windpipe. We've got to be careful and remember that wheeze comes from down in the chest, the airways down in the chest, but stridor is usually from the main windpipe or the trachea, and that, just to remember, is a noise that occurs on breathing in rather than breathing out. But all of this can be very confusing. And although as health professionals, we're supposed to know the difference, we often don't. And then to expect parents to know the difference is really, really difficult. So one of the options could be that perhaps this noise that we're really interested in and that's really important can be detected with a monitor, such as this one here, which is placed on the child's chest when they're feeling unwell by the parent. It's just one place that it needs to be put, just below the right clavicle. And the microphone and sound piece within the device is trained to detect the high-pitched noise of wheeze. And if there is a wheeze present, then a light tells the parent, yes, a wheeze is present. So this is one way we can kind of overcome the issue of difficulty in diagnosing wheeze. And to understand whether this type of detector is helpful, whether parents find it helpful, and whether it's feasible in the home, this is some data from a pilot study that's been done. So it was a trial where children aged 9 to 6 years who had a known diagnosis of wheezing, the families were given this device to say, please do some monitoring every day for 30 days. The first thing to note is the families only did it for 80% of the days. So families don't necessarily always use something even when they're invested in it, and we've got to remember that. And then if we look at what the parents thought of the ease of use of the device, 80% thought it was uncomplicated and could be used easily, and half thought it was there were no concerns and no problems occurred. But in half, or at least in a third, the problem was the child wouldn't tolerate it, wouldn't stay still. So the age range was wide here, 9 months to 6 years, and you can imagine probably the end of the 4 and 5 year olds would have tolerated it fine, but perhaps for really young toddlers, some improvements need to be made. And then if the parents were asked, did they find this helpful, then about 70% thought they'd like to know more about it, perhaps use it again. And about half thought it was helpful and would recommend it to others. Now, this is extremely pilot data and really needs to be extended out to a much wider population to understand more about the utility. So when you want to know whether the child in front of you really does have wheezing, you've not only got to think about the sound and the noisy breathing and the difficulty in breathing, but you've got to remember that there are conditions other than straightforward wheezing stroke asthma that can cause this narrowing of the airways. And you've got to make sure that there are no other diagnoses explaining these child symptoms. So think about suspicious features in the history, unusual findings on examination. And when you've got a child that's presenting again and again and again and not responding to the usual treatment, you must question the diagnosis. And to really understand whether it's wheezing, ask the parents during your history taking about open-ended questions. Where is the noise coming from? Is it up here? In which case it's probably stridor, or is it lower down in the chest? In which case it's more likely to be wheeze. Ask the parents if they can mimic the noise. Ideally, doctor confirmed wheezing. And in this day of an age of smartphones, ask them to record the noise on their smartphone or try and use a video. And just some red flags I wanted to highlight that should make you suspicious and think this might not be straightforward. If the symptoms are present right from birth, it's unlikely to be straightforward preschool wheezing. If the child has got an associated productive cough, which is wet sounding and rattly, it's unlikely to be straightforward wheezing. If the child's not gaining weight or growing, that's very, very concerning. And as I've said, if they're not responding to treatment, question the diagnosis. And this is kind of a list of differential diagnoses that you should think about when you're seeing these patients. So just a really very quick overview of what to do when you're presented with a child who's got a true acute wheezing episode. So during the acute attack, there's not much you can do other than give bronchodilators. And that can be a short-acting bronchodilator or an anticholinergic, and definitely measure oxygen saturations and give oxygen therapy if they're hypoxic. The one thing I would say is please don't reach for a nebulizer straight away. We have good evidence that you can see here that if a child has normal oxygen saturations, then using a metered dose inhaler with a spacer for the bronchodilator is very, very effective. And Evie will go through the details of how to administer that. And again, Evie's going to talk in detail about this, but nothing will work if it's not given properly. So if the child's swallowing their treatment, it's not going to work. If they're drinking their treatment, it's not going to work. You must make sure they're taking their treatment properly for it to be effective. Get the basics right. And not only must they take the treatment properly, but they must actually take the treatment. Adherence to treatment is critical in making sure there's a response. And you can see some data that we've generated here that shows only the children who had preschool wheeze and had adherence to their treatment of at least 60% improved over a period of time. If they don't take their treatment, obviously they're not going to get better. And then what about using steroids during an acute attack in these preschoolers? Well, overall, unfortunately, we don't have evidence that a short course of oral steroids is helpful in preschool wheezing, either from the point of view of hospital admissions or emergency department visits. And this is quite different to older children with asthma. The preschoolers tend not to respond to short courses of oral steroids. And the only time I would suggest that oral steroids should be used is if a child has a really severe attack such that they're needing oxygen and they're kind of heading towards the high dependency unit. Otherwise, there's no evidence for benefit for oral steroids. Montelukast, which is a leukotriene receptor antagonist, should that be used for an acute attack? Well, no, we've got good data to say it really doesn't change anything for an acute attack. And then what about using treatments to try and prevent attacks? What should we be using maintenance inhaled steroids in these patients with preschool wheezing? Well, the thing to remember here is the reason we use maintenance inhaled steroids in any child with wheezing or asthma, no matter what their age, is to dampen eosinophils in their airways, and they're shown here on this slide. So really, you need to know that the child in front of you has got evidence of airway eosinophilia for those inhaled steroids to be effective. And this trial has shown really nicely how to identify the children that are most likely to respond to inhaled steroids. This was the infant trial that included children aged between 1 and 6 who had symptoms of wheezing with acute attacks and daily symptoms. And they were randomized to either inhaled steroids, leukotriene receptor antagonists, or placebo. And the thing that became apparent was that there was a real group who definitely responded to inhaled steroids, and they're the red lines shown here, who had the fewest attacks when they were given inhaled steroids. And what characterized those children were the ones who had allergen sensitization and elevated blood eosinophils. So these are the two markers that we now use to help decide which children should be given inhaled steroids. This is more data from the infant trial, and you can see that the children that had both allergen sensitization, the red line, and elevated eosinophils had the probability of the best response to inhaled steroids. And what we're doing is we're looking for blood eosinophils, not by a formal blood test. We're using finger prick eosinophils, just like a child with diabetes, you'd measure their blood glucose with a finger prick. We're doing the same to look for blood eosinophils in these children. And skin prick tests are easy to do in the clinic to really understand who's going to respond to the inhaled steroids. So what have I said? Well, get the diagnosis right. And if you have a child that keeps presenting with recurrent and severe attacks, don't just keep escalating treatment, investigate and consider a specialist referral. And for the children who benefit from inhaled steroids, look for aeroallergen sensitization and elevated blood eosinophils, mainly because inappropriate steroids might cause harm and adverse effects. Remember the basics, and Eve is definitely going to talk to you about that. And that's it from me. Thanks very much.
Thank you, Sejal. So I'm Evie, and I'm the clinical research nurse. I'm just going to go through, as Sejal said, the sort of basics of management for children with wheeze, so for wheezing young children. So the three sort of basics really to make sure that they've got correct inhaler technique, that they're compliant or adherent to their treatment, and preventative measures. So I'll talk about those. We know that inhaler technique is really important, so choosing the correct inhaler device is key. Using a spacer device makes the inhaler easier and more efficient to use, and this is because it increases the amount of medication that gets into the lungs, and it reduces the side effects as more medication goes directly into the lungs. Children under 3 years of age will need to use a spacer and a mask, but most children aged 3 years and older should use a spacer with a mouthpiece. So there are different types of inhaler devices around, but the most appropriate for a child under 5 is a metered dose inhaler and a spacer. So this is just showing you a picture of a spacer with a mouthpiece at the top and a spacer with a mask at the bottom. Why use a mouthpiece in children 3 years and older? So this increases the amount of medication getting into the lung, as less is deposited on the face and up the nose, making it more effective. It also reduces the side effects of medication being deposited on the face and going up the nose. So this is just a diagram explaining how to use the spacer and mask. So the first step is to remove the inhaler cap. shake it and attach to the end of the spacer. Make sure that there is a good seal around the nose and mouth. Then you press down on the inhaler once, and then you wait for your child to take 10 breaths, or you can count to 10 slowly. And then you repeat the above steps for further doses. So the important thing is, if you're needing to give another puff of inhaler, that you give it another shake and then follow the steps. And this is how to use a spacer with a mouthpiece. So again, remove the inhaler cap, shake and attach to the end of the spacer. Make sure the child's placed their lips around the mouthpiece. Press down firmly on the inhaler once, and then they breathe slowly 3 to 5 times. So it's 3 to 5 nice sort of slow deep breaths in and out. And then just repeat the above steps for every extra puff that you need to take. And again, if you need to give a second puff, to make sure you shake the inhaler before you give that. Compliance is an important issue, as Sajal has shown in her slides and talked about. So it's really important, if they're having a steroid inhaler, to make sure that you give it every day. And this is because the medication builds up over time. There are other preventative measures as well. So we know that smoking isn't good for wheeze. Exposure to environmental tobacco smoke makes wheeze worse. So it's something we talk about in our clinic. It's important to ask about smoke exposure in the home and to signpost parents or carers towards smoking cessation advice. And this is just some feedback we had from the family of a 4-year-old patient who has recurrent wheeze. And this was using the Omron wheeze scan device, which Sajal had shown in the previous slide. So they took it home, they used it for a couple of weeks. And the feedback from the parent was that it was easy to use. It always detected wheeze unless there was a lot of background noise or if the child had their mouth open, because it's quite sensitive to picking up sound. But it always detected wheeze when the child was wheezy at night. So the parents found that useful. And now I'll hand over to Liz. Thank you.
Thank you, Evie. So I have 3 wheeze case presentations, and the aim for me is really to sort of highlight some of the key points which Sajal and Evie have already touched on, and key points to consider when assessing a child with wheeze and deciding how to manage them. So case 1 is a 2-year-old boy. So typical case. So he was brought in by his mum to the primary care clinic by the GP, and the mother had presented with a 3-day history of cold symptoms and reported that the child sounded wheezy. And it's noted when the mother entered the room that she smelt really strongly of cigarette smoke. And mum reported that since he'd been unwell with the cold symptoms, that he'd been using the blue inhaler, 2 puffs every 6 hours roughly. And the mum reported that this always seems to happen, then it seems to be triggered when he has a cold, and that he's entirely well in between. And on further questioning, he doesn't have hay fever or eczema, and there's no strong family history of asthma or any atopy. And on review of the computer records, you can see that the child's had 4 previous hospital admissions with wheeze, all with similar presentations with cold symptoms, and has had a previous HDU, so a high dependency unit admission, which the child required high flow oxygen and an IV treatment for the wheeze. And they also, importantly, were born at term and they're thriving. There are no concerns documented about the child's weight gain. So what would you do next? Would you examine the patient, check the inhaler technique, give the mum a wheeze plan to follow at home, discuss the mother's smoking with her, consider maybe it's worthwhile referring the child to a pediatrician, or would you do all of the above? So the answer is all of the above. First things first is to examine the patient, no matter how combative the child is. So it's important to do a full examination. So if possible, ideally, it's difficult with these toddlers, but to get the T-shirt off so you can get a really good look to see at their work of breathing. But if not, to try and maximize, if the child's quiet, to start with listening to the chest first. But the child on examination looked pink, smiling, warm, well perfused, active and bouncing around the room. There is no increased work of breathing. The breathing rate, you check it and it's normal, and you happen to have an oxygen saturation measurement and it's 100%. And when you listen, there's really good equal air entry and just mild scattered expiratory wheeze. So impression is that this child has wheeze, which has been triggered by the viral illness, they're clinically stable and you feel they're safe to go home, and you give the mother some advice. The other things that is really important to do when you see the child is that you check the salbutamol inhaler technique, discuss and agree a wheeze plan, discuss smoking cessation with the mother, and refer to a pediatrician. So just to highlight the key learning points from this case. So like Evie's explained before, anytime when reviewing a child with a severe episode of wheeze, it's really important to take that opportunity to make sure that the child's inhaler technique is correct, and that it's being used, that they're using a mask or a mouthpiece, depending on their age, and that it's appropriate and they're using a spacer when they're taking their inhalers. Importantly, at this point, you should make sure that the parents have an up-to-date wheeze action plan, which they understand. So it's not good enough to just give it to them and say, this is what you do, but to make sure that the parents are aware of what they should do when the child has wheeze, and should their symptoms get worse at home, and how to escalate and where to seek help. And it's important to offer, like Evie's mentioned earlier, smoking cessation support. And if you're in obviously primary care services, this would be directly through primary care, and if you're in secondary care, by referring the parents to primary care for help with this. And it's important to offer support to stop cessation every time you see the parents. And importantly, it's important to consider and recognise when to refer to secondary care and indeed tertiary care. And the current guidance from BTS is that all children that have had 2 courses of oral steroids within a year should be referred to be seen by a paediatric specialist with an interest in asthma, or indeed a tertiary care clinic. And this particular child had, from their background, like I mentioned before, had a severe episode of wheeze, which resulted in an HDU admission. And rightly so, this child was referred to a tertiary care clinic because of a severity, and also the fact that they had recurrent episodes of wheeze resulting in hospital admission. So they were appropriately referred for a specialist respiratory opinion and investigation. And this child, as mentioned before, had objective tests to determine their atopic testing. And like Sajal mentioned, this can include skin prick testing, as well as full blood count to look for eosinophil count. For children who do have a blood test, we do also do total IgE and specific IgEs to common air allergens. And in children who are over age 5 and above, fractional exhaled nitric oxide should be conducted. And this is an indirect measurement of eosinophilic airway inflammation, and spirometry to get an assessment to see whether or not there's obstructive airways disease. Other investigations which are done when seen in the tertiary care clinic are to, as Sajal mentioned earlier on, is to investigate for alternative and coexisting diagnoses. So the kind of investigations which we would be doing would be including a sweat test to see whether or not to exclude a diagnosis of cystic fibrosis, a chest x-ray, basic tests to assess immune response. So this would include immunoglobulins and vaccine antibody responses to tetanus and pneumococcal, as well as MBL, mannose binding lectin, to look for MBL deficiency. And importantly, the children which we see, we also work, so a child which is seen in a tertiary care clinic is reviewed by the whole multidisciplinary team, and this includes a review by a speech and language therapist to assess for any abnormal, assess for swallowing difficulties, to see whether or not this is contributing and in fact causing their symptoms. And finally, it's really important, as mentioned before, that the basics are got right. So to have a review by an asthma clinical nurse specialist, which includes adherence check, inhaler technique check, asthma plan update and discussion, as well as a urine cotinine test, which can be used to assess for smoke exposure. So this child, the GP had already started medium dose inhaled corticosteroids. And this was reduced on reviewing clinic as the parents were concerned about the side effects to a low dose. And the child was given a trial of a leukotriene receptor antagonist for 6 to 12 weeks. And it's important to note that this is effective in a minority of patients, and that it can cause disturbed sleep and nightmares. So it's really important, if you're considering starting a montelukast, to warn parents of this possible side effects. And this child improved with this treatment, and they didn't have any side effects, reassuringly. They, in fact, didn't have any further hospital admissions. And they had, from the objective testing, they had a raised eosinophil count. They had negative skin prick testing, but in light of the raised eosinophil count, they continued with their inhaled corticosteroid treatment. So the second case is a 20-month-old boy referred to tertiary respiratory clinic by secondary care. And he had had recurrent severe episodes of wheeze, which had been described in the referral letter as bronchiolitis, so as they had occurred sort of in the first sort of year of life or so, as well as viral-induced wheeze. And this child had had, as per the previous child, an HD admission and required high-flow oxygen. Currently, the child was on low-dose inhaled corticosteroids. So on reviewing the history when referred to the respiratory clinic, the mother reported rapid breathing from 5 months old. And she'd noticed that actually the salbutamol, though she was using it when the child was unwell, was not really making that much difference. And she noticed that actually when the child got unwell and was admitted to hospital, she felt that actually it was the antibiotics that were making a difference. And that on other occasions when the child didn't require admission, that actually things seemed to get better when the GP prescribed antibiotics rather than giving steroids. She'd also noticed on further exploration of the history that the child snores at night and gags with dry textures, but hadn't noticed any choking with liquids. Reassuringly, the child was growing well, had been born at term. The symptoms had started from 5 months old. And there wasn't any family history of any chest conditions. They didn't have any pets in the home. No one was smoking, and they had wooden flooring throughout the home. So what would you do next? Would you admit the child for a bronchoscopy, sweat test, bloods, a pH study to look for reflux, a review to assess their swallow by a speech and language therapist? Would you increase their dose of inhaled corticosteroids and review in 8 weeks? Or would you say to the mother, this is normal. It's okay for children to have rapid breathing. He's a toddler. Toddlers have viral illnesses common, and it can happen very often, not to worry. So what to do is to admit for further investigation. And in the tertiary care clinic, we admit for further investigation because it's really important, like I've said before, is to consider alternative diagnosis or coexisting diagnosis. And this is why it's really important if a child is not responding to treatment and is having recurrent severe episodes of wheeze, it's really important that they are referred for investigation to consider the presence of other conditions and to be fully investigated. So this child had a bronchoscopy to examine the structure of their lower airways, as well as obtain lower airway samples to look for the presence of to assess whether or not they've got neutrophilia in their airways or eosinophilic inflammation, as well as to obtain samples for microbiology and virology. So this child on bronchoscopy had features suspicious of a vascular ring. So there was pulsatile narrowing of the trachea. And so a vascular ring is a malformation of the aortic arch, and this can cause partial or complete obstruction of the trachea, and it can present with wheeze, and is a possibility in this child. And in terms of confirming it, further investigation would be needed. But the important thing is that having had the bronchoscopy, it was suspicious for this. On their lavage, there was evidence of neutrophilia, and there was moderate growth of Streptococcus pneumoniae and Haemophilus influenza. They had normal immune screen, their sweat test was normal, their bedside assessment of their swallow and video fluoroscopy, which is a dynamic X-ray imaging in which the child would swallow barium, and they'd swallow different textures of food and liquid to assess their swallow with different thicknesses of liquid and also with solids. And their pH study was entirely normal for this child, which is again looking for reflux, which can also cause similar symptoms. So this child, in light of the growths from their lavage, was treated with a 4-week course of oral augmentin, and they've had a CT chest with contrast arranged, which is still waiting to see whether or not the results, see whether the child has a vascular ring underlying. So the important learning points and why I selected this case was to highlight that several things. First of all, cough post-viral infection can last up to 3 weeks. that's normal, that's okay. But if a child is having persistent rattly breathing or wet cough, even if they are a toddler, this isn't normal, and that needs further investigation. And the third case is a 4-year-old girl. And this particular example is a child seen in primary care centre. And she'd had 4 courses of oral steroids within the last year. And she gets wheezy every time that she has a cold. Sibling has asthma. And the mother's really concerned, can she be the same as her sister? On a further questioning, she has a nut allergy. She wheezes and coughs after she runs around in school, not just when she gets a cold. And mum thinks that she's wheezy after she cuddles the family dog. So when you examine her, you can't hear a wheeze and no wheeze is heard. So what do you do next? Do you say the mother's right? She's wheezy, she's just like her sister, and you start a low dose inhaled steroid and review in 6 to 12 weeks? Do you refer to a pediatrician at hospital with special interest in respiratory, or do you ask the mother to come back when the child is wheezy? So both 1 and 2 are correct, but I think the important thing to remember is that that's if a physician has confirmed wheeze previously. But to add on to point 1, and also to follow on with what Sajal has suggested earlier on, it's really important to remember that inhaled corticosteroids, not all children respond to inhaled corticosteroids, and it's really important to have objective evidence that they have ongoing eosinophilic airway inflammation, or that they would actually respond to treatment. So in children, like mentioned before, and this particular figure is taken from a paper published by Saglani in Allergy, which outlines a suggested approach for starting inhaled corticosteroid treatment. And as mentioned before, this involves assessment for peripheral eosinophilia, so blood eosinophils more than 0.3, as well as the presence of air allergen sensitization, which can be assessed using skin prick testing or a blood test. So in summary, I think my slides confirm that the child, it's really important to it's really important to confirm that the child has wheeze. And second of all, it's really important to make sure that the basics are got right. And this includes checking the inhaler device being used, and checking that that's appropriate for their age, checking the technique, ensuring that the child and the parents have a wheeze action plan and they know how to follow it, and that it's up to date and they have it somewhere close to hand. Thirdly, to recognise when to refer to secondary care, and that's when the child has had 2 courses of oral steroids within the last 12 months, but also if there is a concern, if there's high parental concern, if there's a concern about the diagnosis, or if you're uncertain. Fourthly, maintenance inhaled corticosteroids are not a treatment to be taken lightly, and they're associated with significant side effects, and there should be objective evidence when deciding whether or not to use them, and this includes the presence of peripheral eosinophilia and or air allergen sensitization. And it's really important to consider alternative and coexisting diagnoses. And if a child is having recurrent severe episodes, it's really important to consider referral to a respiratory pediatrician.
Thank you all for these really interesting presentations. And now it's time for our live Q&A session. Sajal, we'll start with a question for you. When should a child with recurrent wheezing be referred for investigations?
Yeah, so I think the main thing is, as Liz mentioned, if they're having frequent and recurrent episodes of wheezing, which are bad enough to need to take them to an emergency department or to be hospitalized, then they need to be referred. And if they're not responding to treatment, so the treatments that we would normally use for wheezing, such as the bronchodilators and or inhaled steroids, if they're not responding, then really they need to be referred, because either something else is going on and this just isn't straightforward wheeze, or perhaps the treatment isn't being given properly or not being given at all. So that they would be the main reasons that I would want to see a child. If you've got any of those suspicious features in the history that we've discussed, and if a child isn't responding to treatment and just having frequent severe episodes, causing them to be seen either in the emergency department or admitted.
Thank you, Sejal. And now a question for Evie. How do I get my child to take their inhalers?
So it can be tricky at first. They don't always like it, but there's a few sort of pointers to help. So it's important to make sure they're nice and calm and not to sort of give it, especially if they're, if they're a baby or something and they're screaming and crying, because actually it's a bit traumatic for everyone, and also they don't get enough of the medication into the airways. So just trying to build it into their routine as well, because it's important to give it every day if it's a steroid inhaler, so that it builds up over time and has some effect. And also with the slightly older sort of preschool children, I can't do my job without access to lots of stickers. I always find that helps. So a little reward chart or something like that can be useful. Thank you for your question.
And a question for you, Liz. What do you do if parents report wheezing, but on examination, wheeze is not heard?
So we discussed this briefly earlier on. So I think there are several ways that you can address this. Ideally, it's really important to hear. It's really important to hear it yourself. One way is for the parents to sort of imitate or act out the sound. Another way is to ask them, and it's really a common way, is that parents have actually usually record an episode of wheeze. So it's quite often that when they come to clinic, they've already recorded a video of an episode, and that's really useful to actually help decide. It's also another alternative, if you don't have this ability, is to have a look and see if a physician has documented an episode of wheeze. And these would be the main strategies that I would take.
On a different topic, if regarding the COVID pandemic, how did that affect wheezing services and recognition of wheezing, and how did it affect any of the children with wheezing problems if they were testing positive for COVID?
So I can probably take that question. So the biggest thing to say is children were not very badly affected by COVID. They're not being very badly affected even now. So they don't get, on the whole, the majority of children don't get very severe disease. And if anything, COVID was beneficial for wheezing, because as we've been saying throughout this session, the biggest precipitant of a wheezing attack in a child is a cold caused by a virus. And what happened during COVID is we were all in lockdown. We were all in our own homes, not mixing with other children. Children weren't going to nurseries. Children weren't going to schools. They weren't getting colds. And so actually, the number of presentations of wheezing reduced significantly during COVID. But now that things are, that the restrictions are being reduced and we're all going back to normal, children are going back to school and nursery, we're seeing the wheezing episodes pick up again, and they're presenting again with wheezing. So there was a kind of a very significant, what we call non-pharmacological benefit from COVID, which was we stopped children getting viruses because they weren't mixing, and actually they were actually quite well. And now we're back to normal. We're going back to baseline.
Yeah. Can I ask about the incidence of wheezing amongst siblings and amongst family? Do you see a pattern in the patients that you are treating?
So it is known that sort of asthma or allergic asthma does tend to have a hereditary component. So if you have a child in front of you who themselves has allergies, or their parents have allergies, it doesn't have to be asthma, even if their parents have got hay fever, eczema, or asthma, then it's much more likely that the child in front of you probably is going to go down the route of having continued wheezing and going on to develop what we call allergic asthma. So there's definitely a significant component of the family history, but that doesn't guarantee that the child in front of you will definitely have wheezing or asthma. There are certain risk factors that you can look at for the child themselves, and that is that they themselves might have eczema or have had eczema as an infant, that's quite a reliable thing. And then, as we've said, looking for evidence of allergies in the child using testing like skin prick testing, where we would test for allergies to house dust, cat, dog, grass, pollen, tree pollen, that kind of thing. So they're all support features. The problem is we don't have a gold standard diagnostic test, either for wheezing or for asthma. So we have to put lots of different bits of information together to really understand what's happening with the child in front of us and how to manage them.
Do children grow out of asthma, Sejal?
So again, it depends what age we're talking about. So the children that we've been discussing today are the under fives, and you'll note that we've been very careful not to say asthma. We've been saying wheezing or preschool wheezing. And that's because it's really hard to be certain that that child in front of you who at the age of 3 that might be having attacks of wheezing will carry on and at school age have asthma. So amongst the under fives, about a half or maybe even 2/3 may not get symptoms beyond the preschool age. At school age, they may not have symptoms. But if you're talking about school age children, then if they have a diagnosis of asthma, they're unlikely to completely grow out of it. Even if they may not have symptoms for some period, those symptoms may well come back either when they're an adult or when they're a bit older.
Okay, so if the clinician is concerned about house dust mites sensitization, what measures should be taken?
Liz, do you want to answer that?
Okay. Yeah. So if there's a concern from the parents that the child might be sensitized to house dust mite, one measure which we can do, so if there is a concern about sensitization to particular air allergen, is to confirm that when they visit the clinic. And we can also assess for other air allergens, which may also be contributing or in addition to that. So this can be confirmed through skin prick testing or blood testing. So if there is a child who is sensitized to house dust mite, we wouldn't advise that you need to remove all the carpet and strip it and, get rid of the carpet in the house. We would advise general sort of daily cleaning advice in terms of using sort of protective bedding, so mattress protectors, pillow protectors in the home, and to make sure that regular vacuum cleaning and dusting is done within the home.
Okay, another question here from the audience. How can we support parents who step up, who step up ICS to double because they feel that the child wheezes without it? They want the ICS changed to the same as their 8-year-old son, but this is not licensed for the child's age. They have been referred to pads, but a long wait. So who would like to answer that question?
So I can take that. So obviously you can't stop parents doing what they do at home. If they want to give double the dose, they're going to give double the dose. What I would say is in the context of children, what we know is increasing the dose of inhaled steroids at the time of symptoms or at the time of worsening symptoms or an attack is not effective. So even if you go up to quadruple the dose of inhaled steroids, it doesn't work if you just do it when the child is symptomatic or having an attack. That really only has been shown to be effective in adults. It doesn't work in children. So the things that I would suggest for a family who are worried about their child's symptoms and you're waiting for the referral is go back to the basics, as we've said, and really make sure, especially you said it's a 5-year-old that they've increased the dose for. Are they giving the inhaler properly? Have they got the right spacer? For example, if that child is still using a spacer with a mouth mask, it won't be effective. And a simple measure that you can take is just give them a spacer with a mouthpiece because it's a 5-year-old and they should be able to do it properly. The only other thing you could suggest, if you're worried about such high doses of treatment, is perhaps while you're waiting for the referral and the appointment, is to add in a leukotriene receptor antagonist, which is a non-steroidal anti-inflammatory, rather than encouraging them to go up to sort of a double dose or high dose of inhaled steroids. Or the other thing you can do is give them a combination device with an inhaled steroid and a long-acting beta agonist. So if the child is just on inhaled steroids, change them over to a combination device which has an inhaled steroid and a long-acting beta agonist in it. And again, that way you might be able to spare some of that steroid, high-dose steroid. So that for a 5-year-old, that they're the kind of main measures that you could be able to think about. Yeah.
Thank you, Sejal. That was a great Q&A discussion. Now I have one final question for the speakers. What are the key messages on the challenges in recognising wheezing in young children that you would like our audience to take away with them from this webinar? Liz, would you like to go first?
Yes, so make sure that the inhaler technique is reviewed when seeing the child, and make sure they have an agreed, up-to-date wheeze action plan.
Evie?
Okay, so it's really, really important if your child's being prescribed a steroid inhaler to make sure you give it every single day.
Sejal?
Yeah, so I think for the preschoolers that we've been discussing today, it's really important to confirm that they definitely have got wheeze and there's nothing else explaining their symptoms. And if you're worried that the child in front of you isn't responding to kind of standard treatments like bronchodilators or inhaled corticosteroids, then think again and refer in for additional investigations just to make sure that there isn't something else that's being missed or that could be contributing to their symptoms not being controlled.
Thank you to Professor Sejal Saglani, Clinical Research Nurse Evie Bingham, and Dr. Liz Scotney for a fascinating exploration of the challenges in recognising wheezing in young children. Thank you also to our audience for joining us today and for the stimulating questions you provided for our speakers. Finally, thank you to Omron for sponsoring this webinar. If you are interested to learn more about paediatric wheeze and get an update on current paediatric asthma treatment, have a look at Omron Academy, an online education platform with content created by medical experts.